They're gonna leave. Exactly.
Kelley, switching gears a little bit, we heard in your long stint up here on the stage this morning a little bit about virtual care models, and you know at Red over the last 4 years being here, we've talked a lot about those, and I think what would be my specific question or thoughts for your comments is around AI specifically, and like what specifically are you doing with AI in that model that many have either tried, adopted, or very interested in doing. So if you could speak to that a little bit, that'd be great.
So earlier when I was talking about the virtual nurses, I talked about how we use the workload planner to try to get at what things do we maybe take off of the nurses. Well, we've done the same kind of work through our predictive analytics and our fall risk. So inside of our EMR, we have a predictive fall score. So we score the patient out with the fall risk when they come in. And then behind the scenes, it pulls in a lot of other data that show to be predictive to a fall risk of the patient and more accurately scores the patient. So now we've been able to pull that data out and use our own fall information to say, do we see trends? Do we see a patient population that we don't have sitters on? And are we sitting with the right patients? And so what we found is not exactly. We might be sitting with patients that are difficult and the staff don't really want to deal with them, or the family's difficult, or they've asked for a sitter so they can go home. But we've really not based it off of that. The real issue is we're trying to solve falls or safety events. So we now have where if a patient is 70 and they're over 100 in a fall score risk, we automatically put a sitter with them. We don't ask, we assign a sitter with them. If they're above 65, we know they're high risk. If they're above 65 with the score 100, so we do safety rounds on them every hour. And we make sure the bed fall alarms are on the patient instead of, the staff, doesn't like always to put bed alarms on patients. And you can have a whole hospital full of bed alarms. So we're really trying to identify what's the right patient to have a bed alarm on. So since we've done that, we've seen a 20% reduction in our falls just because we've better identified the patient that we should be having the sitter with versus letting the staff or the physician tell us who we should have a sitter with.
And the data with the AI on top of it is leading
is leading it. So it's helping us identify all of that it's bringing forward what we couldn't see inside of all the data.
How does the team, the staff that's interacting and being led on the hour, it sounds like, how does that, we saw the question, right? Humans worried about decision making on their jobs. How do they think about it?
So it has dashboards, and so you can click into the dashboard and you can see exactly what's making the patient score 100 or higher on their fall risk. So you right away can make the determination, yes, you think that's accurate and they're a really high fall risk, or
it's not a black box where you don't know exactly.
Yeah, you can click and it'll tell you what's exactly making up that score. And so they
keeps them engaged.
It doesn't, but they would tell you if they were sitting here that 99% of the time it's accurate, and it's the patient that we really need to have a sitter with. It's not really over scoring. Where we would find, they would tell you that any nurse would tell you the Morris fall skill over predicts everybody. It just tells you everybody's a high fall risk. If you have an IV, you're gonna be a high fall risk. So if you check into the hospital, you're high fall.
It's a risk adverse process.
So it's just like that. That would be what it would tell you. So they camera in, make sure all the high risk interventions are done on the